So now, if you remember what I told you in the last presentation, autoimmunity is the root from food poisoning. Now we're going to go, well, what are the leaves on the tree, and how can we treat the leaves until we can fix the root? And so now we talk about SIBO, IMO, ISO, SIFO, and all of that. So the tradition of SIBO is from the 1960s. You had a Billroth 2 or a blind loop syndrome, or you had an antrectomy because we didn't have PPIs. We just took the stomach, cut it out, and then you get SIBO. Well, the antrectomy will give you malabsorption. The Billroth 2 will give you malabsorption, but then you blame it on the SIBO. So we don't see these B12 deficiencies in modern SIBO. So what I'm going to be talking to you about is modern SIBO, which is more common. But there is a list of things that cause SIBO, so don't forget. Don't always say it's IBS, that it's IBS and SIBO together, because there are many things, as you know, scleroderma, uncontrolled diabetes can cause it, pancreatic insufficiency, and on down the list. But I will talk about the myths, as I was asked to. Is SIBO a cause of IBS? I'm going to talk about that. Is SIBO just simply the bacteria of the colon coming into the small intestine? Another old concept. That is not what SIBO is. Not in 2025. I'll show you what SIBO is. And is breath testing a measure of transit? That is not true in 2025 as of 5 days ago when a publication came out, as we suspected. But we're going to go through all of these myths, and by the end of it, hopefully clear everything up. So let's talk about now in the context of IBS, because that's the one that's most clearly understood. And when we talk about the microbiome as a condition or as a phenomenon, really now IBS is the poster child of microbiome, because we know so much about the microbiome and its cause and effect in humans. But this is 25 studies comparing breath tests in IBS to healthy people. Breath test is a lot more often positive in IBS than healthy. So this is a very clear answer. And 15 of these studies in this meta-analysis are considered high quality. So we know breath testing is more positive. This study just came out a few days ago, and it did a transit study with lactulose in 100 controls, roughly 100 people who should have SIBO because they have Billroth 2 or they have scleroderma or they have something like that, and then 100 IBS patients. And then they treated all the IBS patients with antibiotic, all of them, no matter what the breath test showed. And what they showed is the transit did not explain the breath test. It wasn't getting to the colon when the hydrogen was going up. They defined that the positive, based on the transit, of 20 by 80 minutes, which is basically what we use, is correct, and that 69% of IBS patients were positive. But only the patients with high hydrogen on breath test improved with the rifaximin. So this is a very important study that you should all take a look at now. But even culturing the small bowel, this is from 2007 from Sweden on the left, another European study on the right from 2012, and basically SIBO is present in 60% of IBS on the right. I'm using the 60% rule again. So about 60% of IBSD, food poisoning to SIBO. That's what we think now. But even with sequencing, so this is now a group of patients who had a breath test. If you look at the 90-minute time point on the breath test, which is the standard time point for SIBO, 20 parts per million rise or greater, it had a good specificity against culture of the small intestine of the same patient, and it correlated with the microbiome on sequencing. But the final column is interesting because the metabolomic function of the small bowel, the higher the enzymes to produce hydrogen were in the small bowel, the higher the hydrogen was on the breath test. So the hydrogen's coming from the small intestine, not the colon. But the problem with breath testing is there are not one gas, there's not one gas, there's not two gases, but there are three gases. It's hydrogen, methane, and hydrogen sulfide. And if you look at methane at the bottom, to make one methane, the organisms, the archaea, need 4 hydrogens to make one methane. So if there's methane on the breath test, the hydrogen on that person's breath test is going to be lower than if the methane wasn't there, because it's eating 4 to 1. Hydrogen sulfide's eating 5 to 1 on the top. So if you have a mixed gas pattern, you can't rely on the hydrogen number. So you have to measure all 3 gases, which is why this is now available in the US. Diarrhea is caused by hydrogen sulfide, and I'll show you that later. And constipation is caused by the methane. So these are causative factors that if you undo it, the patient gets better. This is the first study ever in history of the shotgun sequencing of the human small intestine, and specifically focusing on patients with SIBO on the right and patients with no SIBO by culture on the left. And you can clearly see yourself that the microbiome is different by the colors. But it's very, very interesting what is actually happening. You can see there's a lot of proteobacteria, but I want to show you this. Remember I said SIBO is not the colon bacteria moving into the small intestine. That's the old way of thinking. SIBO is only Klebsiella and E. coli. That's it. These 2 characters make up almost all the organisms in the patient with SIBO. So it's really quite very different than we expected. And the higher these organisms are, they destroy everything around them. But they're special, and I'll tell you why they're special for these patients, because this is the biggest wrecking ball for the microbiome that we see in our Reimagine study, which studies the small intestinal microbiome. An antibiotic, if you're taking an antibiotic right now, will destroy your microbiome. If you have SIBO, your microbiome is destroyed. Those 2 things are the strongest, most destructive forces in the microbiome that we have seen in Reimagine. But it may even be more specific. It may even be E. coli K12, a specific strain, because it correlates with all the symptoms of IBS. But what I want to show you here is I want you to think about this. SIBO, if you look at a patient with SIBO and look at the metabolic potential of that microbiome and compare it to a normal microbiome. Because the E. coli and Klebsiella are there, you have 2 Ferraris in your small bowel that can ferment better than any other bacteria that are there. And you're 63 times faster at fermenting carbohydrates than the person next to you. So when a patient tells you I ate food and 10 minutes later I have gas, it's because they have Ferraris in their small intestine making the gas so quickly. E. coli and Klebsiella are so aggressive. This is how much gas they produce, how fast. So think about that when you talk to your patients. Well, now breath testing is very well accepted. We started with the North American consensus in 2018. Now there's a European guideline or consensus. The Asia Pacific, including Australia, is part of this guideline, and Brazil got into the mix recently with their guideline. And basically, it's pretty global understanding that breath testing is important. This is how you should do it. Breath testing is more positive in IBS. They're related. And so we have quite a consensus across the globe now on this. But I mentioned there are 3 gases. And so it's amazing that breath testing has been around since the early 1980s, even sooner, and nobody's ever done a study where you take the breath test, you take culture of the small bowel, you sequence the small bowel, and you have symptoms, until this study, which we did in IBS. So this is the first study ever. You have 3 gas breath testing, the microbiome, and the symptoms. We have patients in a FDA trial who had constipation IBS, and patients who had diarrhea IBS in blue. If you have diarrhea IBS, as you can see here, the blue, they have no methane, almost never. Only the constipated patients have methane, and about 60% of them have methane, and it looks like that. The diarrhea patients in blue have hydrogen, and they meet the criteria, most of them, for SIBO because it's more than 20. But I want you to look at the constipated patients with methane. The hydrogen is lower than the other constipated patients because the methane is eating the hydrogen and affects the breath test. And then finally, hydrogen sulfide is higher in patients with IBS-D. We now know the bugs. For for the first time in this last 2 to 3 years, we figured out all the bugs. I told you E. coli and Klebsiella for SIBO. It's M. smithii, Methanobrevibacter smithii, is the cause of the constipation and the methane in humans. And you can see it here, and it correlates, the bugs, the Methanobrevibacter smithii correlates directly with every time point on the breath test, every single time point. So, and you can see here, just interestingly, the higher the methane, the more negative the hydrogen because it eats hydrogen, which I just said earlier. But if you take the bacteria that we know that produce hydrogen sulfide in humans and you put them in animals, they get diarrhea and they produce hydrogen sulfide in their stool. So we know that hydrogen sulfide is causing the diarrhea part of things. And finally, for the first time, just published, it's actually just been published. If you compare the breath right now and then go in and scope the patient and look to see if methanogens are there in the small intestine, what you saw as methane in the breath correlates with the amount of methanogens in the small intestine. So again, what I'm trying to tell you is the breath test tells you small bowel. That's what it's telling you. And it's Methanobrevibacter smithii 63% of the time. If you put methane, this is an older study, if you put methane into the gut, just push it as a gas, you get 60% slowing of transit. And one of the things I teach the fellows is you don't slow transit by paralyzing the gut, you slow transit by making the gut stop everything, by squeezing. And methane is doing that. This is oxygen in a bath with helium in the bath, and this is methane with the oxygen. The gut is spastic. It's not contracting, it's spasming, and nothing moves. And so methane is causing spasms and holding things in. So there's now a meta-analysis. Methane means constipation on the left. Methane means less diarrhea, which is the same thing on the right. This is an interesting study from Stanford where they did a smart pill. If you're methane, your smart pill is slower. Colon transit and small bowel transit, whole gut transit are slower. In hydrogen sulfide, same thing. If you measure hydrogen sulfide in the breath, we know the bugs in the small bowel that are producing the hydrogen sulfide, and they're elevated. For this case, Proteus mirabilis is producing hydrogen sulfide. And then people say, well, should I do a glucose breath test or a lactulose breath test? I don't know if you have these discussions, but glucose breath testing, glucose gets absorbed. If you give me glucose, I'm going to absorb it in my mouth, I'm going to absorb it in my throat, in my esophagus, in my stomach, because for a diabetic, you put a candy under their tongue and the sugar goes up. You're absorbing that. Lactulose never gets absorbed. So in me, the glucose getting to the small bowel may be less if I drank glucose than somebody who may be smaller. And so glucose is a problem. You're not sure how much gets there. The second thing is it gets absorbed so quickly in the small bowel, it never gets to the second half of the gut, so you're missing overgrowth. Well, we saw in this study of nearly 6,000 patients getting a questionnaire, and there's over 3,000 patients who finished the questionnaire. If you did glucose, and you were negative on the breath test, you were sicker than a patient who was negative for lactulose. I know it's hard to understand, but basically, glucose breath testing is missing a bunch of people who are sick. So you really should do lactulose. And this is just showing in this 6,000 patient study, the higher the hydrogen sulfide, the more severe these patients had diarrhea. So this is not the conclusion of the presentation, this is the conclusion of all this microbiome work. Hydrogen sulfide checks off all the boxes of what we know were IBS because we looked at the transcriptome of biopsies from humans who had a breath test, who had hydrogen sulfide, and compared it to the hydrogen sulfide we put into animals. And what we see are all the things we know happen in IBS, like visceral hyperalgesia, changes in motility parameters, fluid comes into the gut, etc. And so this is duplicating everything we've always known about irritable bowel syndrome. So basically, this is the framework for IBS. About 60% of IBS is either ISO or SIBO, diarrhea side. And about 60% of constipation IBS is IMO. And now we know the organisms and which ones are acting in the small bowel, which ones are acting in the colon, where they live, how they live, and this allows us to move to the next level, which is new drugs, which I'll get to at the end. And on the IMO side, it's methanobrevibacter in the top, and it's methanobrevibacter in the bottom. So you know about the rifaximin for irritable bowel syndrome. This is the Target 1 and 2 trials. They show that rifaximin works for IBS. But if you just give rifaximin to just anybody with IBS, you have a 44% chance that that patient will respond using Target 3, just open label. But if you know they have SIBO, if you did a breath test and it was positive, their chance of responding is now 56%. And if the rifaximin actually made the breath test normal, that person was 76% likely to meet the FDA endpoint. So knowing they have SIBO, treating that patient, and making sure they get to normal is what gets you the best result possible. So is rifaximin the best drug for this, or almost there? I'll tell you at the end. But this is a rifaximin meta-analysis for just SIBO. Doesn't matter what cause. So rifaximin works for SIBO. We know that from this meta-analysis. SIBO predicts your response to antibiotics in IBS. This is a meta-analysis of should you do breath testing in IBS or not? And the answer is if you do a breath test and it's positive, you're more likely to respond to antibiotics. So it suggests you should. I know this is a complicated slide. This is from the group in Cork, Ireland, and this is probably going to answer a question that would be asked in the question session. Are you hurting the gut by giving rifaximin or an antibiotic? And the answer is, think of the E. coli, the Ferraris, as weeds in the garden. If you get rid of the weeds, the garden grows back. And what they showed in this study, looking at every study ever done on IBS microbiome, the two important organisms that they found were E. coli and Klebsiella and Fusobacterium, which produces hydrogen sulfide, those three, sorry. But on the right, and it's very complicated, but I'm going to summarize it for you, when they looked at the studies where microbiome was done before and after rifaximin, the patients who got better because they got a reduction in E. coli, Klebsiella, and Fusobacterium. And those patients, their microbiome started to go to normal. We're heading towards what a normal microbiome looks like. So by getting rid of the weeds, the normal microbiome has a chance to come back because the Ferraris are gone. They're not eating everything. So I show this slide to all gastroenterologists in the world because every gastroenterologist at my hospital does this. If you give food poisoning to rats, but the day before, the day of, and the day after the food poisoning, you give them rifaximin, they do not get IBS. And so the point is, could we prevent IBS if we're going somewhere or eating somewhere where we know there's a chance of food poisoning, street food, for example? If you took prophylaxis, would it prevent IBS? And according to rats, the answer is yes. So prophylaxis might actually prevent it. Now, if you have methane, things are different. Rifaximin alone doesn't work. We give neomycin plus rifaximin in this study. This was a double-blind study where if you give those two together, those are the patients that did better in terms of constipation and reducing methane. We don't know what to do with hydrogen sulfide right today, except we know bismuth works very well at reducing or killing hydrogen sulfide-producing organisms. So we combine it with rifaximin, and that's how we treat the ones with hydrogen sulfide. We also have a new elemental diet that is very good at getting rid of bacterial overgrowth. Basically, it's food, it gets absorbed so quickly by the gut, the bacteria starve to death. And so you're basically resetting the microbiome with an elemental diet, and I could discuss this more in questions. But I point this out because now, the last consensus or guideline we had on irritable bowel syndrome in the United States was in 2018. We haven't had one in 6 years. But the Indian consensus finally has the ability to use some of this new data I've shown you. And in their guidelines, they say patients with IBS of the D type are more likely to have SIBO, accept completely, and a grade A recommendation. Second is that methane causes constipation in IBS-C, accepted, and grade B recommendation, level 1 evidence. And food poisoning causes IBS, grade A recommendation. So the guidelines are now saying this is what we should be doing for IBS. So I think that's really important. Finally, and this is the first international conference, I'm speaking about these two very exciting things. I gave you 5 minutes before, so now I'm going to take my 5 minutes. So it's only 3 or 4 more slides. We've now are working on a drug that goes into the socket of the enzyme that produces methane in the methane bacteria, Methanobrevibacter smithii, which is an archaea, not a bacteria. And in the animal study on the right, we presented at DDW, the constipation improves and the methane goes down. And we're about a year away from starting human trials of a drug that reduces methane in vitro by 80% and in rumen of cows by 80%. So it has a human play and a potential greenhouse gas play. So it's a drug for a bug. It's not an antibiotic, doesn't kill them, it just blocks methane synthesis. We now know that rifaximin doesn't work in as many people as we like because rifaximin is hydrophobic, doesn't get into the liquid layer, and half of the E. coli and Klebsiella live in the mucus versus the free fluid layer. So we added NAC to rifaximin in a randomized control trial. This is rifaximin, full dose, small study, so that's why not a lot of p-values, because this is a pilot trial. But yes, pain is better, gas is better. If you add NAC, almost everything gets better. And so we are in a phase 2b study of a special delivery system with a special dose of rifaximin and NAC, and we can get more IBS patients better because we now know where the E. coli and Klebsiella live. So this is what we do. This is now what I'm doing in my clinic. The future is coming. I'm going to talk to you about that in 1 second, but we do what I said on the middle. If you're intestinal sulfite overproduction, we do rifaximin with Pepto-Bismol. If we have SIBO, we give rifaximin, sometimes the elemental diet. And for IMO, we give rifaximin with neomycin. You could substitute metronidazole if you like, or the elemental diet. I'm excited about the new rifaximin drug. I'm excited about the new methane drug. And I told you about the biologic agent that could get rid of the antibody. So lots of new exciting things are coming. So one slide on fungal overgrowth and then my conclusion slide. Fungal overgrowth is much less studied. We have looked at this in about 100 patients with SIBO, maybe 2 have SIFO if you go in and culture and do sequencing. So it is there, and when it's there, these patients have bloating and pain, and sometimes they respond to an antifungal, so we are doing that more and more, but there's a lot more data that has to come here. So in conclusion, IBS is a disease. It is not a syndrome, so we should get rid of the S because we know a lot more about IBS now than we ever did. Food poisoning causes a significant portion of IBS. IBS Smart and TrioSmart, IBS Smart is the blood test, TrioSmart is the new 3-gas breath test, are the most validated tests in history for IBS. This is not your grandpa's SIBO. This is modern SIBO. This is the modern understanding using next generation sequencing. And now we're having drugs, because of all this information, that could really get to the root cause and help these patients. Thank you.